Good evening. This is Dr. Johnson Miller, and I would like to thank everyone for attending our virtual meeting. We're really excited to present these great speakers to discuss what's new in the treatment of breast cancer based on breast cancer tumor genomics, as well as genetic testing in patients who may be at high risk for breast cancer. We also like to address some concerns about breast cancer imaging, which sometimes is conflicting viewpoints in the lay media, as well as how to navigate the financial landscape in breast cancer treatment, imaging, and follow-up, as well as stress management. If you're identified as having a high risk for developing breast cancer, as well as for patients who are diagnosed with breast cancer. So our speakers will be Nicole Salvatore. She is a certified genetic counselor that works with the HMH Hospital Network and is primarily located at Jersey Shore Medical Center in the Hope Tower and at Ocean Medical Center. And she's looking at what the differences are in risk factors based on a genetic profile and who should get genetic testing. Dr. Shingala is a breast imaging fellowship trained radiologist who is employed by University of Radiology and works at Jersey Shore. And she's going to address some of the screening issues of who should be screened, when screening should begin, and why we order some of the breast imaging tests that we do. Christina Turner is a licensed social worker at Hackensack Meridian Jersey Shore University Medical Center and is located within Hope Tower as well. And she's going to go over not only the concerns about finances when faced with a breast cancer diagnosis or a genetic diagnosis, but also what resources may be available. Dr. Ruchi Bhatt is a certified medical oncologist, physician, and treats many patients with breast cancer. And she's going to go over the latest facts and literature research on how we are using our newest research, genomics, in planning your treatment. And David Leopold follows, and he's going to go through the holistic approach of stress management that is so important for good outcomes when you are diagnosed with breast cancer, as well as managing these life events if you're diagnosed with a genetic mutation that increases your risk of breast or other solid tumor cancers. I think you will find this to be extremely interesting, and we will have time for questions at the end of all of the presentations. Thank you very much for attending. We look forward to your feedback.
Hi everybody, I'm Nicole Salvatore. I'm a cancer genetic counselor here at Jersey Shore University Medical Center. And today I'll be talking about the differences between genetic testing and genomic testing. So first I'm going to just give a quick genetics lesson to understand the science between these two tests, and then I'll go into what genetic testing is and hereditary cancer syndromes, and then genomic testing and how that's used. So just our Genetics 101 lesson. Our body is composed of cells, and in every cell in our body, we have 23 pairs of chromosomes. Chromosomes are essentially a big DNA molecule, and within chromosomes, we have different genes. Genes are segments of a DNA that are each responsible for a different function. So some of them are helping with our metabolism, some of them are helping with our neurological function, and then there's a subset of them that are supposed to be protecting us from cancer. When genes have mistakes in them, they're called mutations. And mutations are when there's a change in the structure of a gene that then doesn't allow it to do its job. So because there's a mistake, it's slacking off at what its purpose is. Mutations can be both inherited, which means passed on from one of your parents, or acquired, which means happens by chance, happens sporadically, either due to aging. As we age, we get more prone to mutations, or due to environmental reasons, exposures. And this is important because cancer can be both inherited or sporadic. This is really the most important message of my talk today, is that all cancers arise from gene mutations. So cancer really comes from our own cells, and when those cells have mutations, they can become cancer. So every cancer at the basis is caused by gene mutations, but that doesn't mean that they're all inherited. And to explain this further, I have this diagram. On the top row there, you can see sporadic cancer. Again, we have 2 copies of every gene in every cell in our body. When one of those genes gets mutated or has a mistake in it, it's not doing its job anymore. But we have that other copy to kind of pick up the slack and still help us with that function. Now, years can go by, decades can go by, and sometimes what will happen is that other copy of that gene will get a mutation as well. And then we have knocked out both of those genes and don't have that function anymore. We're not getting protected from cancer anymore. So tumors can develop, which can then become cancerous. That's a sporadic cancer evolution. On the second row, there's hereditary cancers. Now, with hereditary cancers, we're born with a mutation. We're born with a mutation in every cell in our body. But again, we still have that other copy that is good and doesn't have a mutation to pick up the slack. And then years and decades can go by, and a mutation can occur in that second copy of that gene, where then cancer can arise, tumors can develop, and that will be the progression of a hereditary cancer syndrome. Now, for the rest of the talk, really just focusing in on what the differences between genetic and genomic testing are. It gets confusing because these 2 tests have a lot of different names associated with them. So healthcare providers can say one of these names, but it means the same thing as, say, genetic testing. This can also be called germline testing because we're looking at the cells and the genes that are passed on to you from your parents. Also called hereditary cancer syndrome testing or family testing. Genomic testing can also be called somatic testing or tumor testing because we're looking at the mutations and the genetics of the tumor itself. Now, for the rest of the talk, when you see this picture of the family tree, I'm talking about genetic testing. When you see these tumor cells picture, that I'll be talking about genomic testing, just as a visual cue to help you, through the rest of this talk. Now, first, genetic testing. This is a test that's typically performed either by saliva or through a blood sample, and it's looking to identify gene mutations that are putting you at an increased risk for cancer. It doesn't tell us that you have cancer or you will develop cancer. It tells us if there's a risk in your lifetime to develop certain types of cancers. It will also tell us if there's other family members at risk for developing certain types of cancers. These mutations are passed on through generations in the family, and this information can give implications and information to children, to siblings, and other family members as well. But most cancer is not hereditary. Only about 5 to 10% of cancers are hereditary. So it's a very small percent. Most cancers are sporadic or due to a combination of other factors, not inherited factors. Some of the features that we see with hereditary cancer syndromes include families where multiple members have the same type of cancer or related cancers across different generations. Now, a lot of people will know about their first-degree relatives, but we also are looking to see in your second and third-degree relatives if there's cancer. So I'm talking about your cousins, your aunts and uncles, grandparents, great-aunts and uncles. We really, during our appointments with patients, we look and draw a really big family tree to see what, if anything, is going on in the family. We also look to see if there's young ages of diagnosis in the family of cancer. So diagnosed under 50. We usually see cancer diagnosed later in life, but if it's diagnosed at a young age, it could be because of a hereditary cause. We also look to see if there's individuals with multiple types of cancers, multiple primary cancers. If there's uncommon cancers in the family, like male breast cancer or ovarian cancer in females. And then certain ethnic populations also have a higher risk for hereditary cancer syndromes, including Ashkenazi Jewish populations and certain Eastern European populations as well. So if we see some of these features in a family or with one of our patients, we want to send them for a genetic counseling appointment where they're going to meet with a genetic counselor. They'll review their personal and family history of cancer, and we'll discuss different hereditary cancer syndromes, what risks go along with them, and then what management, would be recommended. When I say management, I mean, preventative surgery options, screening changes, or taking medication to reduce the risk of cancer as much as possible, or risk of second cancer. It's not going to tell us anything currently about if this patient has cancer, anything about that diagnosis. It's just going to give us risk numbers. It'll also, during a genetic counseling appointment, talk about, again, the family, who should get testing, what risks they might have. And then we'll talk about genetic testing options. A lot of people have heard of the BRCA1 and BRCA2 testing, but now we do test for a lot more than just those two genes. Sometimes we do test with 80 plus different genes on them with different combination of cancer risks. So if you've had genetic testing in the past, it might be important to, go back and get more testing since there's a lot of new options out there. On the flip side, genomic testing. Genomic testing is testing that's performed on the tumor itself, sometimes followed up with a blood sample. And they're looking to characterize mutations in that tumor. So tumor cells are going to be different than the rest of our cells because, again, there's been some type of change or mutation that has led them to become a tumor. And the implications of this test can include finding pathways in that tumor to target treatments and better personalized treatment to attack that tumor better than, somebody else diagnosed with the same type of cancer. Looking at prognosis as well for a cancer diagnosis, what the recurrence risk is, giving us information about how a disease is progressing, and then also if somebody could qualify for clinical trials. So there's a lot of information that can come from genomic testing, primarily about a current diagnosis and how to best care for that patient. There's a lot of overlap with this testing, with these two types of tests. In general, tumors just have a high rate of mutations. Again, that's what cancer is. It's our cells with mutations not doing their job anymore. Typically, it's not inherited though. So when we do a tumor test or genomic test, sometimes it can increase our suspicions and say, well, this looks like it could be a hereditary cause, and then we would want to follow up with genetic testing. Sometimes genetic testing also will tell us information about a targetable, marker in a tumor that might give us better information about treatment for a patient as well. So these tests really work together well, but they are different. So if you've had one, doesn't necessarily mean that you've had the other. So again, if you have questions, talk to your healthcare providers about what test you've had done. So just in summary, again, the big message is most cancers are not hereditary. It's only about 5 to 10% of the time that they will be. Genetic testing is going to tell us if a cancer is hereditary or if there's risk to other family members. And then genomic testing, again, is more about an active cancer diagnosis. How are you going to best treat that? And what are the best, options moving forward for our cancer patients? And that's it for me, so thank you for having me, and I'll take questions.
Hi, my name is Prapti Shingala. I'm a breast and body radiologist at University Radiology Group. Today I'll be talking about breast cancer screening in high-risk population. So mammographic screening has reduced breast cancer mortality by 40 to 47%. Mammographic screening is instrumental in determining a large percent of breast cancers before it is palpable, at a smaller size, at an earlier stage, and when it is more likely to be curable. So the American College of Radiology currently recommends that annual mammographic screening starts at the age of 40 for women at average risk for breast cancer. Average risk for breast cancer is considered to be less than a 15% risk of developing breast cancer. So less than 15% is considered to be average risk, whereas 15 to 20% is considered to be intermediate risk, and greater than 20% is considered high risk. So higher than average risk women may require earlier or more intensive screening. They're more likely to be diagnosed with larger cancers that have lymph nodes that are positive, and experience higher interval cancer rates. Therefore, it is our current recommendation that all women should receive a risk assessment of their lifetime risk of breast cancer, with particular emphasis every woman of African American and Ashkenazi Jewish descent be assessed and identified by the age of 30. Therefore, appropriate screening for higher risk women can commence by age 30 or whenever it is deemed necessary. So who is considered at high risk? Women with genetic mutations, like the ones listed here, are considered to be at high risk. Known genetic predispositions account for 5 to 10% of breast cancers. In addition, women with strong family history in the absence of genetic mutation can also be considered at high risk. Currently, the Tyrer-Cuzick model is the most accurate for assessment of breast cancer risk. However, many of these models do not take into account breast density, which has been proven to be another contributing factor to an increased risk of breast cancer. Women treated with chest or mantle radiation therapy between the age of 10 and 30 are also considered to be at high risk. In addition, women with a personal history of breast cancer. So women that were diagnosed with ER-positive cancers are at an increased risk for future cancer development, and women diagnosed at or before the age of 50 and treated with breast cancer therapy have a 20% or higher lifetime risk of developing a new breast cancer. So what are the imaging modalities that we use to screen? The gold standard is screening mammography. Digital breast tomosynthesis, or 3D mammography, detects more cancers, is more sensitive in dense breast tissue, and recalls less false positives than 2D mammography. As you can see on the picture on the left, this is a traditional 2D mammography, and the area in question, or the suspicious finding, is buried under all the breast tissue. Everything is white. But here on the right, you can see clearly the spiculated mass under question, and this is with 3D mammography. So screening mammography for high-risk women should not begin before the age of 25, because breast cancers rarely develop in women before that age. Breast tissue in very young women is often dense and difficult to see, and breast tissue in young women may have an increased risk to radiation. Contrast-enhanced breast MRI is another imaging modality that we use to screen women in high-risk populations. It is very sensitive in cancer detection in high-risk women than either mammography or ultrasound. Studies have shown in BRCA carriers there's a 68 to 90% breast cancer detection rate using MRI compared to 37 using mammography and 32 to 37.5 using ultrasound. In high-risk populations, MRI and mammography combined have a higher sensitivity of about 92.7% compared to ultrasound and mammography, which has a sensitivity of about 52%. Screening breast ultrasound is also a supplemental imaging modality that can be used. Multiple studies have found a cancer detection rate of 3.2 to 4.3 per 1,000 patients using screen breast ultrasound. However, there may be an increased risk of false positives. A false positive is an abnormal study even though there is no cancer present. So BRCA1 and BRCA2 are genes that produce tumor suppressor proteins. These proteins help repair damaged DNA. So mutations in BRCA1 and BRCA2 can cause DNA damage which is not repaired properly. This, left unchecked, can lead to cancers. The breast cancer risk for BRCA1 is 57 to 87%, and the breast cancer risk for BRCA2 is 43 to 84%. Other cancer risks include ovarian, prostate, pancreas, and melanoma. So the current recommendations are for women at age 25 to 30, they should get a breast MRI every year, and mammogram only if breast MRI is unavailable. Women greater than the age of 30 should have a breast MRI and a mammogram every year. Ideally, the screening mammogram and breast MRI should be staggered every 6 months. There is some concern about young women with an inherited cancer predisposition having an increased risk to radiation. Therefore, screening mammography should not start until the age of 30, but definitely not before the age of 25. So first-degree relatives with a BRCA1-2 gene mutation, but they haven't been tested for BRCA1 or 2 themselves, for ages 30 or older, the NCCN, or the National Comprehensive Cancer Network, recommends mammograms every year, as does the ACR, or the American College of Radiology. For breast MRI, it's recommended to discuss this with your doctor and then ultimately to screen also every year. So TP53 gene mutation, or Li-Fraumeni syndrome, this is caused by mutations of the TP53 suppressor gene. So this mutation will allow for DNA damage to continue to divide. The breast cancer risk is 49 to 54%. Other cancer risks include adrenocorticocarcinomas, CNS tumors, osteosarcomas, and soft tissue sarcomas. Current recommendations are at between age 20 to 29 to start screening with breast MRI every year, and only to use a mammogram if breast MRI is unavailable. Ages 30 to older, you should supplement with breast MRI and mammogram every year. The P10 mutation is a tumor suppressor gene. It also is associated with the P10 hamartoma tumor syndrome. The breast cancer risk in this population is 77 to 85%. Other cancer risks include colon, thyroid, endometrial, renal, and skin. Current recommendations for screening for ages 25 to older is starting at age 30 to 35 or 5 to 10 years before the age of the youngest breast cancer case in the family, whatever comes first. PALB2 is also known as a partner and localizer of BRCA2. BRCA1 and BRCA2 genes interact with PALB2 to help repair damaged DNA. The breast cancer risk for PALB2 mutation is 17 to 58%, with other cancer risks including pancreas and male breast cancer. So the current recommendations are to screen with mammogram and breast MRI every year at age 30. STK11 is a gene that codes for an enzyme that is a tumor suppressor, and it is also can cause Peutz-Jeghers syndrome, which is a condition characterized by hamartomas in the gastrointestinal tract and an increased risk of developing other types of cancers, including colorectal, pancreatic, stomach, small bowel, lung, ovarian, and testicular cancer. Breast cancer risk is 8 to 45%. And the current recommendations for screening mammography is every year starting at age 40, and breast MRI at this time is not recommended. CDH1 is a gene that provides instructions for making a protein called E-cadherin. This is a protein that helps with cells to stick to one another, cellular adhesion. The lobular breast cancer risk in patients with this genetic mutation is 39 to 52%. Other breast cancer risks include diffuse gastric cancer. Current recommendations for screening is to start with a screening breast MRI, to discuss that with your physician at the age of 30, and to do screening mammograms every year starting at the age of 30. ATM provides instructions for making a protein that is located in the nucleus of the cell, where it helps control the rate at which cells can grow and divide. The breast cancer risk in this population is 24 to 60%, and other cancer risks include prostate and pancreas cancer. And the current recommendations are to start with the screening mammogram every year at the age of 40, and to talk to your healthcare provider at the age of 40 about supplementing with a breast MRI. And CHEK2 mutation CHEK2 is a gene that helps with assisting DNA repair. The breast cancer risk in patients with CHEK2 mutation is 25 to 39%. Other breast cancer risks include colorectal cancer, male breast cancer, prostate, thyroid, ovarian, and kidney. Current recommendations include screening mammogram every year at age 40, and to also talk to your healthcare provider about supplementing with breast MRI starting at the age of 40. So in conclusion, it is very important to talk to your healthcare provider regarding your risk for developing breast cancer and the need for supplemental and earlier breast cancer screening. An informed patient is an empowered patient. Thank you.
Good evening, my name is Christina Turner. I'm an oncology social worker here at Hackensack Meridian Health. As an oncology social worker, I'm here to meet with patients when they begin treatment, so chemotherapy and radiation. I'm here to assess their needs, and I provide emotional support and encouragement, as well as education and connection to community resources. So today we're going to talk a little bit about financial concerns and resources related to breast cancer. We're going to begin by talking about some of the resources related to the emotional component of a breast cancer diagnosis. And where we start is really by building the support system. And for everyone, that support system is going to look a little bit different. And you're going to do this by talking with your family and your loved ones. So here are some tips for effective communication. You want to make sure that you're sharing the facts, as well as being honest, and you want to use age-appropriate terms. So the way that you're going to describe a diagnosis and the terminology that you're going to use speaking to your significant other is going to look and sound really different than the terms and that you'll use when you speak with a young child. The Cancer Council of Australia created this book. It's called Talking to Kids About Cancer. It's a really great book because it breaks it down by age group, and it gives you tips and suggestions about possible reactions and how to speak with your child. So if you have a child at home, I would really recommend this book. You can Google it and download a free PDF. I also have a link at the end of the presentation. Another aspect to effective communication is to utilize active listening. So that means that everyone needs to be free from distractions. We want to make sure that phones, the TV, all of those things are off. We don't want to have the conversation in a car ride that's going to end in 10 minutes. And we also want to talk about one topic at a time. You want to make sure that your statements are really specific and clear. So there's a difference between me saying to you, "You're so messy," and me saying, "Please clean up your dishes." When I say "you're so messy," I could really be talking about anything. So you want to make sure that you identify for the individual that you're speaking to exactly what it is that you're talking about. The next part is that the cancer diagnosis affects the entire family. And these are a few ways that it might impact your family. The first being that it often changes the roles, the responsibilities, and the dynamics. This means that if you were previously the primary caregiver, you might have to take on a more dependent role. If you were the individual that was doing the yard work or the chores around the house, you might now need some assistance and help to complete those activities. The next topic is emotionally, and it's really going to impact everyone in a different way, and everyone's going to have different emotional needs. So this is where the effective communication really comes into play. Another area is the possible genetic implications. So you want to talk with your oncologist to find out if you qualify for genetic testing. If you do, you'll meet with a genetic counselor and they'll help you to determine what information needs to be shared with your family and how to do this. The next area is the financial area, and this can impact a family for the individual who has the diagnosis. If you were working, you may now have to take some time off from work. If you were a full-time worker, you might drop down to part-time. There's also the financial component of treatment itself, and we're going to get into some of those topics in a minute. A foundation that we're going to discuss called the Pink Fund completed a survey in 2017 of 1,000 women who had a breast cancer diagnosis, and they found that 1/3 of these women were more concerned with the cost of treatment versus the actual cancer diagnosis itself. So we know that the financial component is a heavy burden, not only for the individual, but the family as well. So some of these, I'm not going to read all of these to you, but some of these you may experience, some of these you may not, and there may be things that I didn't include on this list. Sometimes we don't think about the cost of transportation. Radiation treatment can be a daily treatment, and if you have to come a long way, those tolls and fees can really add up quickly. If you don't have a car, paying for an Uber or a taxi. We talked earlier about genetic testing. This is really important, and it can sometimes have fees associated with it. Fertility can be another cost. Chemotherapy and radiation can impact the fertility of both men and women. So if you are interested in having children, it's important to speak with your oncologist to see if you should be seeking fertility treatment before chemotherapy and radiation or after, potentially both. And clinics can be a little costly, so it's nice to know that there are resources to help with these financial costs. Durable medical equipment, this could be something that you may need in the home, like a walker, a cane, a shower chair. Cool caps, also known as cold caps, are caps that both men and women can wear on their head during chemotherapy, and it helps to prevent hair loss and to slow the process. These also have a financial cost, as well as wigs. Sometimes your insurance will help pay for coverage, and other times this can be an out-of-pocket cost. So what can we do about all of these financial concerns? There are resources out there. The first place you want to start is to check your insurance. If you find that you're underinsured, you want to make sure that you get that coverage that you need. Now would be a great time to do so. It's open enrollment. It began on November 1st, and you can do this by going to the marketplace. It's healthcare.gov, and you can check to see what other plans are out there. Or if you need that supplemental insurance, now would be the time to apply. If you qualify, you can apply for Medicaid, and this is something that you can apply for year-round. You don't have to wait for an open enrollment or a qualifying life event. Also, talk with your hospital to see if they have an assistance program that you might be eligible for. Another area is to talk with your nurse navigator or your oncology doctor's office to find out if you can apply for any assistance programs directly through the drug companies themselves. So the next 3 items on this slide are nationwide support programs, and they're specific to breast cancer. They provide financial support to patients, and it's the Pink Fund. The Susan Komen Fund has a treatment assistance program which covers a wide array of needs. The United Breast Cancer Foundation, which has a grant not only for the individual, but also a breast reconstructive grant. And then locally here in New Jersey, we also have some really great resources. The 2 here that are specific to breast cancer are Breast Intentions and Just Us Girls. Just Us Girls is really nice because despite the name, they help both men and women. And the other foundations local to New Jersey is the Beauty Foundation, David's Dream and Believe, and Stomp the Monster. All of these foundations, the nationwide ones and the ones local to New Jersey, can be applied for by the patient, but it's important that you speak with your oncology social worker and nurse navigator to find out what the requirements are, who needs to submit the application. A lot of them are one-time grants, and it does take a little while for processing, but it's really great that we have these resources to provide to our patients. So in summary, breast cancer diagnosis really does affect the entire family, and we want to make sure that we're utilizing effective communication techniques to have those important conversations. We want to know the possible genetic implications, and this is where, if you qualify, it's really important to speak to the genetic counselor. The financial concerns and resources impact everyone differently, and we have the resources out there, so make sure you ask. Here at Hackensack Meridian, we have a really great support team. You get a genetic counselor, a social worker, a nurse navigator, as well as a dietitian, and we have integrative health services. Check with your hospital to see what kind of support team they can provide for you. So these are just the resources, and right here is the link. It's a little long, but again, if you Google Talking to Kids About Cancer by the Cancer Council, the link should come right up, and it's a free download. If you have any questions, please feel free to let us know. Thank you for having me tonight.
Hi, my name is Dr. Ruchi Bhatt. I'm a medical oncologist and a hematologist with Hackensack Meridian Health, and I'm honored to present today at the Susan G. Komen Genomics Conference. A big thank you to Susan G. Komen as well as Dr. Johnson Miller for providing me with this opportunity to present on new treatments using genomics to build a treatment plan. So what is genomics? Genomics is a study of the entirety of a single individual's genes. It is sequencing and analysis of a person's genome, which can help understand the disease process. When we talk about genomic pathology, it focuses on understanding the genetic and the molecular makeup of a person's disease, and from that we can have some guidance regarding our treatment options for the same. Next, we're going to talk about precision oncology. So precision oncology is an innovative approach to find targeted therapies to specific mutations driving the cancer in an individual patient. It takes into account the individual variability in genes in addition to lifestyle and environment in order to accurately treat a specific patient instead of a one-size-fits-all approach. So if your cancer has a specific mutation, precision oncology is the study of finding drugs that are targeting that specific mutation so that your cancer can be treated for you as an individual and not for everybody. So just a brief overview about breast cancer before we delve into the genomics and further specifics. So breast cancer is the most common invasive cancer in women, second most common cause of death in women. There are various histologies and subtypes, but for the general population, for the audience here, invasive ductal, invasive lobular are the two main types of breast cancer that we see. These are further divided into ER/PR positive, HER2 negative, triple positive, which are hormone receptor positive, as well as HER2 positive, and triple negative, ER/PR, and HER2 negative. And then we'll go into more details about these in the next couple of slides. Also, a brief talk about genetics in breast cancer. So about 5 to 10% of the breast cancer is hereditary with a number of recognized genes and syndromes. So most people hear about is the BRCA1 and BRCA2. There is also Li-Fraumeni syndrome, which is the P53 mutation. There's Cowden syndrome, which has the P10 mutations. There is Peutz-Jeghers syndrome, and then there is hereditary diffuse gastric syndrome, which has a CDH1 E-cadherin gene mutation. So these are some of the genes that and mutations in these leads to breast cancer in women and a couple of other cancers as well. But here we're going to focus on the breast cancer portion. So what is our basic approach to breast cancer? It's a multidisciplinary treatment with surgery, radiation, chemotherapy, and hormonal therapy. So those are our four main lines of treatment. Surgery could be a lumpectomy or a mastectomy. Lumpectomy is when just the cancer is removed. Mastectomy is when the whole breast is removed. These patients end up getting radiation based on the type of surgery which is performed as well as the nodal status. For a person who gets a lumpectomy, they almost always end up having radiation. For patients with mastectomy, the radiation depends whether on a couple of factors such as number of nodes involved, size of the tumor, etc. And following surgery, there is options for chemotherapy, endocrine therapy, and anti-HER2 new therapy. And these treatments are given by the medical oncologist, and that depends on the stage and the receptor cancer of the breast cancer, receptor status of the breast cancer. So adjuvant treatments for breast cancer, meaning when we're treating breast cancer for cure, and then we're giving treatment after the surgery to prevent the local recurrence or systemic recurrence of the cancer. So for patients who are ER negative and HER2 new negative, the only option that we have is chemotherapy, and these patients usually end up getting chemotherapy after they get surgery. For patients that are ER negative and HER2 positive, they get chemotherapy, and they also get therapy that is directed towards the HER2 receptor. For patients who are ER positive and HER2 negative, they definitely get an endocrine therapy, which is an oral pill, but they may or may not get chemo depending on the size and other factors that we will delve into. For patients who are ER positive and HER2 positive, get endocrine treatment, which is the oral pills, plus chemotherapy and plus the anti-HER2 new treatment. So now what is the role of genomics in the adjuvant treatment of breast cancer? So for some specific cancers such as ER/PR positive and HER2 negative with early stage disease, which is stage 1 or stage 2, a breast cancer recurrence score is performed on the tumor sample, and that gives us information about the biology of the tumor to decide for adjuvant chemotherapy recommendations. So Oncotype DX is the name of the score that is most commonly used. It measures the expression of 21 genes and gives a score that predicts the benefits of chemotherapy in this population. So if a person scores 0 to 25, there is no benefit from the chemotherapy, and they always end up just getting the oral endocrine treatment. If the score is between 25 and 100, these patients have substantial benefits from chemotherapy, and they get chemotherapy in addition to the endocrine treatment. There are other assays such as MammaPrint and breast cancer index, but usually Oncotype DX is the score that is used, and it was used in the TAILOR-X study, which is a big study in the breast cancer world. So this is how genomics is used in the adjuvant treatment planning of breast cancer. Now we're going to talk about metastatic breast cancer. So breast cancer is considered metastatic when it travels from the breast to a distant site, such as bones, brain, or other vascular organs such as lung, liver, etc. And the treatment of metastatic breast cancer differs based on the histology and the receptor status, like we have spoken about earlier. So we're going to talk about some of the most common first-line treatment options for patients who are ER/PR positive and HER2 negative. There are these specific medications known as CDK4/6 inhibitors plus the endocrine treatment, which could be tamoxifen or aromatase inhibitors such as letrozole or anastrozole, which are the oral pills, or fulvestrant, which is an injection. For patients who are triple negative, who don't have any of these receptors, they usually get single-agent chemotherapy, which is the IV chemotherapy such as taxanes, platinum agents, anthracyclines, gemcitabine, etc. These are your IV chemotherapy given on a weekly regimen or different chemotherapy schedules. For the HER2-positive disease, the first-line chemotherapy is usually docetaxel, trastuzumab, and pertuzumab, which are all IV chemotherapy options. Now, how does genomics play a role in metastatic breast cancer? So next-generation sequencing, there are panels and genetic testing that are available that detect various mutations in the tumor sample as well as the peripheral blood. It's usually performed when patients progress on the first-line treatment that we discussed earlier, which is why I wanted to go over the first-line treatment so that we know when the genomic testing is performed. So patients with advanced breast cancer who have recurrent genomic alterations detected by targeted panel tests, if they have mutations such as ERB2, PIK3CA, AKT1, and ESR1, or NTRK fusions, deficient MMR, or high tumor mutational burden, they should be considered for early referral for clinical trials. And now we also have some FDA-approved treatments for some of these mutations. I know this is a lot of verbiage for a lot of people, so we're going to go into each mutation and talk about the options that we have for treatment. So if a patient is found to have BRCA1 or BRCA2 mutation, in the US, which is 1 in 400 people have this mutation, there are two medications called olaparib and talazoparib, which are approved by the FDA for the treatment of patients with metastatic breast cancer found to have the BRCA mutation in the germline, or they're suspected to have the BRCA mutation. And they have to be HER2 negative, and they have to be treated with chemotherapy in the neoadjuvant, adjuvant, or metastatic setting. So let's say you have stage 4 breast cancer, you already got the chemotherapy, and then there is still more progression of disease after the chemotherapy, and if you have the BRCA mutation, then we can use these pills called olaparib and talazoparib. So we can also extend the use in some patients who have the somatic mutations, and there is also emerging evidence that patients who have these BRCA mutations, a certain type of chemotherapy called platinum, is more effective in these patients. So we keep that in mind when deciding the treatment options. So just a bit about dosing and administration. So it's a pill, which is easier to take compared to the IV chemotherapy. Olaparib is given twice a day, and talazoparib is given once a day. The mechanism of action is a PARP inhibitor, and the major side effects, which I know is a concern for a lot of people, is GI side effects such as nausea and vomiting. You can have immunosuppression and myelosuppression, which is lowering of your blood counts, and sometimes cancers such as MDS or acute myeloid leukemia can happen with this, but the incidence is low of these side effects. Now, if you're found to have the PIK3CA mutation, which is present in about 10 to 40% of the breast cancer patients, there is an FDA treatment approved for that. It's called alpelisib. It's given in combination with the IM injection called fulvestrant. It's for postmenopausal women who have ER/PR, which are the hormones receptor positive and HER2 negative breast cancer, which has the PIK3CA mutation, which would be diagnosed on the genomic testing that is performed. And it has to be advanced or metastatic breast cancer, and it should be detected by an FDA-approved test, the mutation. So alpelisib, again, is an oral medication, 300 milligrams once a day until disease progression or acceptable toxicity. It's an inhibitor of the PI3K and has a strong activity against the PI3K alpha. So, and the major side effects include hyperglycemia, diarrhea, and skin rash. So again, this is also an oral option, so much better than the IV that you would have to come into the infusion center to take. These are medications that you can take at home if you have these mutations. The next mutation we're going to talk about is the TRK fusions. These are mutations in the NTRK genes. They are identified in a variety of adult and pediatric patients. There are two drugs, entrectinib and larotrectinib, which are oral inhibitors of the TRK proteins that are then they're both FDA approved for solid tumors with NTRK fusions. It's a tumor agnostic approval, meaning if your tumor has this mutation, regardless of where the tumor came from, be it breast or lung or kidney or any other solid organ, you can, if you have the NTRK mutation, then you can get these medications. These two medications, again, are oral. The entrectinib is once a day, and the larotrectinib is twice a day. It inhibits the TRK mutation, inhibits the tropomyosin receptor tyrosine kinases, and the side effects are edema, cytopenias, some visual disturbances, nausea, vomiting, fatigue, neuro and hepatotoxicity. But usually these patients, we treat them, we see them almost every 2 to 3 weeks, see how they're doing, and we can, tailor the dosing, etc., depending on the side effects. If the tumor is found to be MSI high, deficient in MMR, or tumor mutation high, again, this is all genomic testing that's performed on your tumor or could be performed in peripheral blood, then you can have the medication called pembrolizumab, which is an immunotherapy targeting PD-1. So it is approved for all solid tumors who have the MSI high, deficient in MMR, or a high tumor mutational burden. Immunotherapy, as most people know now, is very, very popular in lung and bladder and renal and a lot of other cancers, but the data is lacking in breast cancer. We don't have enough data to support the use in breast cancer yet. Keytruda or pembrolizumab is given IV. It is 200 milligrams once every 3 weeks or 400 every 6 weeks. It is a PD-1 humanized monoclonal antibody, and the major side effects from the immunotherapy are itis of any organ system, meaning inflammation of any organ system, most commonly lung inflammation and colitis, which is the colon inflammation. If you happen to have the ERBB2 mutation, it codes for the HER2 that we talked about earlier. It's present on in about 2 to 4% of the breast cancers, and there are some trials going on that are evaluating the activity of neratinib in these patients. Again, an oral medication targeting the HER2 receptor. If you have the KT1 mutation, then there are also trials going on with some preliminary data available. But if your tumor is found to have these mutations, you might be referred to a clinical trial by your treating medical oncologist. If you have the ESR1 alteration, they're infrequent in primary ER-positive breast cancer. The activating mutations can be detected in tumor samples or cfDNA from the patients, and they sometimes confer resistance to the aromatase inhibitor, the oral therapy that we talked about earlier. There is this class of medications called selective estrogen receptor degraders, which are being studied in this setting at this time. And there is some preclinical activity noted. So in conclusion, and our future goals, the neogenomics or next generation sequencing allows for sequencing of a single gene, targeted genes, or the entire genome. It reliably identifies mutations and estimates the mutation frequency in the DNA. And it provides for prognostic and predictive information, provides for information for the drugs that we can use targeting these specific mutations. And then in more clinical implications of the cell-free DNA and the minimal residual disease are upcoming in clinical trials and soon in clinical practice. And more to come on that. So thank you for your time, and I'm open for any questions.
Hi, I'm Dr. David Leopold. I'm the Network Medical Director for Hackensack Meridian Health Integrative Health and Medicine, and I'm very excited today to share with you some concepts regarding cancer prevention, resiliency, stress management that I think are going to make a very positive impact on your overall health and wellness. So the first thing I wanted to start with was sort of a landmark study from several years ago, and you might be saying, well, why is he talking about prostate cancer in this case? But this was a fantastic study done by Dr. Dean Ornish, and what they clearly showed in this study was that, in fact, you could change the epigenetics or the presentation of the genetic material in people who had prostate cancer. And so what this showed us was that you can actually affect disease, cancer, by changing some lifestyle parameters. In this case, they used physical activity and nutrition to change the genetic profile. And so that obviously can be directly translated into the way that people who have positive testing for high likelihood of having cancer, we can actually change what's going to happen in the future. So we're not locked in. So the overall concept here is one of resilience, and for me, resilience is a really core concept. It's really our ability to adapt to a situation or to bounce back given adversity, but I think that it is much more broad than that. And I think that what I really see resilience as for my patients is sort of this core set of skills, a toolbox, if you will, that helps us deal with the overall stress of life and a way to ensure that we have healthier overall well-being as we go forward. So what I found is that while a lot of us think of stress management and resilience as purely a psychological endeavor, in other words, how are we going to manage all of our stress, I think that's only one piece of the picture. And in my experience with my patients, the important thing is that we look at this in a really comprehensive manner. And so when I see patients, what I try to do is build an entire set of resilience and of skills. So we focus, yes, on things like resilience, stress management, so we'll talk about that, but also it's important that we have healthy overall physical parameters. So it's important to know what someone is eating, what are their sleep patterns, what are they doing for physical activity, and finally, a real exciting emerging component of health and well-being is that of purpose, meaning in life, essentially positivity. And so we're going to talk about that as we go forward. And I think it's important to understand that these are fluid, they're dynamic, they are interdependent, and it's virtually impossible to master all of these at any given time. And so we often are sort of moving from one to the other. So we can try to do the best we can to optimize them, but because they're dependent on each other, really it ebbs and flows based on an individual's situation at any given time. So let's start off with nutrition because it's the one that I think people get very, very clearly. So clearly it matters what we eat. We are what we eat, and going back a long time now, major organizations have identified protective dietary patterns that are associated with less of an incidence or occurrence of cancer. And so those generally focus around things that we would consider plant-based type diets, Mediterranean type diet, traditional Asian type diet, really anything that focuses more on plants, nuts, seeds, less on meat, fish in there at some point, but also avoiding things like refined foods, heavily sugared foods, heavily processed foods, and a limiting of our alcohol intake and a limiting of salt. And of course, salt is often very high in processed foods. So avoiding fried foods as well. And so again, trying to focus on sort of a whole foods type diet, one that is as close to nature as we can get, and using a judicious use of spices. And so we'll talk about that. But clearly, this type of a dietary pattern is associated with less incidence of cancer. And so for those who have a higher predisposition for a malignancy, it seems very warranted that we would want to utilize this type of a dietary approach. And so it's no longer really just saying eat your fruits and vegetables because we think they're good for you. We now have extensive information that tells us that plant-based foods in general, also to some degree spices, ginger, rosemary, turmeric, paprika, whatever you'd like, they have potent activity inside of the body. And basically what they do is they regulate the inflammatory process. We see here that a lot of the things that we actually target with some of our medications for cancer, they're going on at a lower level plants, with some of the chemical compounds of plants. So our recommendation is to eat at least 5 to 10 fruits and vegetables every day. And one of the ways that we do that is we simply start off with filling half of our plate with plant-based foods. I like for my patients to work with nutritionists if possible, but I think that really with these things, it's all about being curious and being willing to go out and try some new things. So trying new fruits, trying new vegetables, different ways to prepare them, and other simple ways to enact these are things like an anti-inflammatory diet, and there's lots of information out there, and the traditional transitional plant-based diet. So not necessarily going completely vegetarian. If you want to do that, that's fine. But again, just transitioning so that at least half of your plate is coming from plants. Exercise is a key component, and there's now extensive information that 2 to 3 hours a week significantly decreases the risk of multiple types of cancers. The opposite of that, unfortunately, is true as well. So sitting actually increases the risk of cancer. So you have two sides of the same coin saying different things. One, if you are physically active, you're going to reduce your cancer risk. The other one, if you sit too long, you're going to increase the risk of cancer. The unfortunate component of the sitting, which we're doing more and more of, is that it's not necessarily, we can't offset that just by exercise. So one of the most important messages there, I feel, is to get up, to move around, and to be as physically active as possible whenever possible. So really, any increase in activity is going to improve your health. And when I talk to my patients, for people who have a hard time starting exercise, I think there's a few things. Number one is anything you do is better than doing nothing. So even if it's just taking a walk, you just walk for 5 or 10 minutes, that's going to be very beneficial. I like for people to do things that they enjoy, so exercise needs to be enjoyable, so dancing or any type of activity that you find enjoyable. And I think it's important that we give ourselves rewards to sort of lock that pattern in. It takes about 12 weeks to start new lifestyle, to really lock in a lifestyle change. And so exercise in particular is one where people very often sort of fall off after a while. So constant and recurring small rewards, I think, can be really beneficial. So listen to a podcast that you wanted, get yourself some new music, buy yourself new workout outfits, whatever it is, anything to keep you going. Mind-body interventions, I can't say enough about mind-body, tremendous amount of emerging evidence on how important this is, and stress really is the X factor in disease. And so we know that when people are in states of higher stress, then typically they have higher levels of inflammation. We know that inflammation generally correlates to an increased likelihood of disease. And this is one that I think is so important. My rule of thumb is that if people don't have an active stress management program that they're involved in for themselves, then stress is almost certainly adversely affecting their health in some way. The good news is that stress management and resilience it's not that hard to do, but you do have to do it on a regular basis. I included the picture of the woman pushing the ball up the hill because we're all under constant stress, and we're never going to live in a stress-free environment, which is why you have to, on a regular basis, offset that. So our brains are predisposed to be in a stressful state. That's a survival mechanism because we needed to know where things that were dangerous were. So we can never fully overcome that, but we can continue to offset it. And generally, when we're in a state of more relaxation, or what we would call parasympathetic state, our inflammation burden goes down, our inflammatory burden goes down, and when we're in a state of constant fight or flight or constant stress, that burden goes up. So you can see that by entering into that relaxed state more often, it's much more beneficial for us. As a side benefit, you're going to sleep better, your mood's going to be better. Really, everything becomes better when you are better able to manage your stress. And so the important concept here is that it has to be done on a regular basis. And so really, if you're going to do stress management, it's really only 2 to 5 minutes twice a day would be optimal, but if you can only do it once a day, then just start with that. Most people think that they can't meditate, or they can't engage in mindfulness activities, or they can't relax because they've been so long in a state of heightened levels of stress that to move into that state of relaxation feels a little bit uncomfortable. I can assure you that anybody can do it, anybody can be trained to do it or taught to do it. It's not that hard, but it does take work to do it. And so I think that's a real critical component. And here's one of the easiest ways to go into stress management, which is really simply breathing. Our body is set up so that when we do slow and controlled breathing exercises and activity, it forces our body into a state of relaxation. It's basically foolproof, which is why I really like it for my patients. And it works essentially immediately. Within 30 seconds of doing some slow controlled breathing exercises, you're going to feel a noticeable decrease in your level of anxiety and stress. The trick is to keep that going, and that's why you have to keep doing it on a regular basis. So we try to target about 6 to 10 breaths per minute, slower and deeper than what you would normally do on a regular basis. The most important thing is that it's what's comfortable for you. But again, any slowed down breathing and controlled breathing, deeper breathing, is going to force the body into a state of relaxation, and it's going to have very profound effects. And I would encourage everyone to try this today. Sleep is incredibly important. It's one of the things that we marginalize in our society, and we know that when people have a constant deficit of sleep, it increases their risk for other disease. Obviously, it increases things like anger, irritability, poor decision making. So sleep is critical for immune function. One of the big things that people always ask me is, how do I improve my immune function? Well, one of the major ways you can do it is to manage stress, eat healthy, exercise, and sleep would be another one of the main components. And so when it comes to sleep, I think that where most people fall short is that they don't plan or prioritize their sleep. And I think that sleep, like anything, you have to set up a plan. You have to say, this is important to me and I'm going to do this. So you have to set up a time that you're going to go to sleep, and you have to set up a time that you're going to wake up that's going to guarantee you about 7 to 8 hours a night. Important for all of these things that get in the way of our sleep. So avoiding stimulants after one. The biggest stimulant that I see that people doing these days is looking at their phone, their screen, the news. So minimizing screen time towards the evening is highly advisable, and avoiding heavy meals, alcohol in the evening can help out significantly as well. So what I really try to encourage my patients to do is to try at least for a week or 2 weeks to really prioritize sleep, do these things that we're talking about here, and then see how different you feel. And for most people, they feel so much better when they're sleeping again that it's worth whatever sacrifice we need to make. And finally, things like meaning, purpose, optimism. There's a tremendous amount of information that's just pouring out of research centers now on the importance of things like a positive attitude for our health. It improves immune function. It obviously improves compliance to certain medical procedures like screening for malignancy. And so basically things that focus on optimism, happiness, these are all things that are teachable. So no matter where anybody is at any stage of their life, you can actually learn how to be more positive, more optimistic. It's really just a matter of practicing those things. So one of the things I like for my patients to do is to spend some time every day focusing on gratitude. A great way to do that is with gratitude journaling, just writing down 2 or 3 things every day, focusing on positive affirmations when you wake up in the morning. But again, we're seeing a tremendous amount of information now on some of the mechanisms of how positivity affects our overall physiology. Things like improving dopamine and serotonin, and particularly oxytocin, the hormone that we release when mothers have their children and when we are in contact with other social beings. So all of these things seem to improve immune function. So another great way to improve your overall immune status by being positive. And so finally, what I hope I've given you today is a comprehensive overview of the way that I think it's best to manage our stress and our resiliency. It's by building a very strong core, a very strong buffer. And what I hope I've given you is a way for you to take control and feel empowered that, in fact, despite having positive tests that indicate that there's a high likelihood of a disease in the future, that you can actually do a lot to bring that locus of control back to yourself. And there's a lot that you can do that actually has very good evidence that it can offset and be protective as you go forward. So I would encourage you to try a lot of the things that we spoke about today, build yourself a comprehensive overall stress and resiliency package, and best in health. Thank you.
I would like to thank all of the speakers for a fantastic job that they did this evening, and thank each and every one of you for listening and participating in this insightful presentation. We do have the chat room open, and I know you've been putting in questions. Our physicians and other speakers will try to answer them as much as possible, but feel free to reach out to individuals. All of the contact information is provided in the seminar. We also have a high-risk multidisciplinary genetic clinic. It meets the fourth Wednesday of every month from 9 to noon, where we see patients that have diagnosed genetic mutations that put them at high risk for a number of solid tumors, breast, colon, thyroid. I'm in the clinic. We have gynae oncology as well as GI surgical oncology. Dr. Leopold is present from integrative medicine, as well as our genetic counselors are available. So that is a resource for you to join, and we could provide that information. My contact information is available as well, so that you know that you can reach out to any of us at any time with questions or concerns. Again, thank you very, very much. And I want to thank the Komen organization, and particularly Suzanne Carson, for putting on this fantastic seminar. Have a great evening.